Center at Georgetown, and she will talk to us about genetic testing and management of breast cancer susceptibility germline mutations. Thank you.
Thank you so much for the kind invitation to be here. It's really exciting, and it's wonderful to see such a crowd of people here. So I'm going to try and focus on both giving you a bit of a review, but also in sharing with you in a little bit more detail some of the more recent data that have emerged on this issue related to genetic testing and management for the breast cancer susceptibility mutations. And here are my disclosures. So I'm going to first focus on BRCA1 and BRCA2. I'm just going to do, as I said, a brief review of where we are, and then share with you in more detail some of the recent studies that have looked at elucidating some of the less common cancers that might be associated with an increased risk in individuals who carry germline mutations in BRCA1 or BRCA2. So this is a graph that I think you're well aware of. We know that these individuals have markedly increased risk for breast cancer and ovarian cancer, and what I've depicted in these graphs is just a cumulative risk by decade for BRCA1 carriers in blue and BRCA2 carriers in green. And on the left, you can see the breast cancer, and on the right, you can see the cumulative risk for ovarian cancer. And when you look at those curves, I think you can understand, or these bar graphs, you can understand why screening recommendations are recommended at different points in time, given the incidence of disease in these individuals. So for instance, if you look at the ovarian cancer risk, you can see that the risk starts to rise earlier in BRCA1 carriers than in BRCA2 carriers. So it's really in the 40s that the risk starts to rise, and that's why there's a recommendation for risk-reducing bilateral salpingo-oophorectomy between the ages of 35 and 40 for a BRCA1 carrier, but it can be pushed off a little bit for BRCA2 carriers. Now, there are other cancer risks, and again, there are tons of publications on this, and what I've tried to do in this talk is take, I think, the best publications that are out there with the most contemporary data to give you an idea of where we are. So I think we're well aware there's an increased risk for prostate cancer, particularly in BRCA2 carriers, but also in BRCA1 carriers. We frequently see this reported as a relative risk. On an individual basis, a patient does not care, and you don't care what their relative risk is. You care what the absolute risk is. And often these relative risks are what gets splashed in the media, what you see in the abstracts. But it's really important to say what's the actual risk for the patient, the absolute risk, so that they can sort out how to best approach things, and you can think about what's going on for these patients. So for prostate cancer, you can see that the risk is estimated to be about 27% for BRCA2 carriers, and BRCA1 carriers is lower. If you look at the male breast cancer risk, while the relative risk is 44-fold excess risk in BRCA2 carriers, the absolute risk is under 4% in this study, and it really ranges from 1 to 7% in studies. So again, you need to put that in context when you think about managing these patients. There are also studies that show increased risk for pancreatic cancer, and again, this is something that mutation carriers are understandably concerned about. This is a malignancy that has a high lethality rate, and I'm going to show you some more recent data on screening for this, but the absolute risk remains low. There's a 3% absolute risk for both BRCA1 and BRCA2 carriers. And if we look at stomach cancer, there are more recent data, including this study that was from a large international database that showed that the cumulative risk of gastric cancer was about 3.5% in BRCA2 carriers and about 1.5% or so in BRCA1 carriers. There are also some thoughts that the cancer risks were a little bit lower for women than for men who carried mutations. And for BRCA1 carriers, there was also some slight excess risk for cholangiotype carcinomas and colorectal cancer, potentially. So I wanted to now delve into endometrial cancer risk because there was a very recent publication that really dissected down on this issue. And this has been a long-standing debate, and I'm going to weave in what we think about prevention at the same time as we're thinking about risk here. Because what we're recommending, obviously, for germline carriers for BRCA1 and BRCA2 is risk-reducing salpingo-oophorectomy. So the question that's always been there is, while you're in there, should you just do a and it's not me who's in there, I'm a med-onc, okay? But while the GYN-onc is in there, why don't they do a hysterectomy? And there's obviously, that's more surgery. It's easier to do these days because many of them are done vaginally, but there are also questions about how that impacts sexual function and a variety of things. And so the question that's out there about endometrial cancer, right, is should we be doing it for prevention? And then the other thing that sort of gets woven into that discussion is the fact that if you're rendering a mutation carrier menopausal, in either her late 30s or by her mid 40s, depending on whether she carries a BRCA1 or BRCA2 mutation, what are you going to do in terms of managing menopausal side effects? And I think many of you are aware if somebody has a uterus in place, you can't give unopposed estrogen. Unopposed estrogen is better in terms of risk for subsequent breast cancer, so you'd have to give estrogen and progestins. And so that's an issue that you really need to talk to the patient about. But I think in your mind, you have to dissect them because you have to figure out, are you thinking about the risk reduction as well? Now, most of the prior studies have been done in the era where the data on management of risk for breast and ovarian cancer weren't included. So unfortunately, many of these mutation carriers might be succumbing early to these cancers, and you might not have seen what the real risk for ovarian cancer is in today's world, where we're really much more aware of how to manage these mutation carriers and reduce their risk for both ovarian cancer and breast cancer. So there was a large Dutch nationwide study that was recently published that looked at the endometrial cancer risk. It had just under 6,000 BRCA1 and BRCA2 carriers from their large Netherlands cohort. And what they did is they compared the risk of endometrial cancer in this cohort, this large cohort with mutations, to the Dutch general population risk of endometrial cancer. And what you can see in this table is I've broken it down by risk for endometrial cancer overall, then serous-like endometrial cancer, and then TP53 mutated endometrial cancer, which is also a more aggressive endometrial cancer subtype. And what you can see is, particularly for BRCA1 carriers, there's an elevated risk for endometrial cancer overall, but more particularly for higher risk, nastier endometrial cancers with a standardized incidence ratio or hazard ratios of about 13 to 15 or 16. The risk is a little bit lower for germline BRCA2 carriers. Again, I've told you it's important to say about what is the absolute risk. So the absolute risk remains very small, okay? So overall, the risk was about 3%, and there was about a 1.1% risk of developing a serous-like endometrial cancer. So how does that incorporate into what we're saying? We talked about the guidelines don't currently recommend risk-reducing hysterectomy, but sometimes we have to factor in this whole issue about hormone replacement therapy to manage premature menopause. I think what these numbers raise questions about is, okay, should we be thinking a little bit more seriously about risk-reducing preventive surgery? I think it's a very personal decision if somebody has a 3% absolute risk or a 1.1% absolute risk, but it's something really to factor in the conversation. But the other thing that I think it raises is a question, if somebody presents with a serous endometrial cancer, should that be a signal for us to recommend that that individual goes on and has germline testing to see whether she carries a BRCA1 or a BRCA2 mutation. And then also what's often the case, unfortunately, what we do is that we don't have information on a more diverse population, and Black women have a much higher rate of serous endometrial cancer, and so it's really important for us to gain more information in this area. So this is just a summary of the management guidelines. Much of this is not new. Okay, you know that you're recommending for screening for breast cancer for mutation carriers. They start getting MRI at age 25, and they do it annually, and that they alternate it with mammogram. Typically, we stagger it, so they're getting imaging every 6 months, but mammography now only starts at age 30, and that's for screening. There's a big debate about whether we should be doing ovarian cancer screening, and I'm going to be showing you a little bit of data that have emerged more recently on maybe a tweak on what we think of as standard CA125 and transvaginal ultrasound screening. In terms of risk reduction, we're discussing risk-reducing bilateral mastectomy. This is for our healthy, unaffected mutation carriers. And we're also recommending risk-reducing bilateral salpingo oophorectomy. I will tell you the NCCN guidelines that just came out a second ago, and you know they'll be obsolete in 2 months when they come out with version gazillion of 2024 already, actually sort of places risk-reducing salpingectomy more in the light of something that we can talk to patients about, okay? And what the rationale for just doing the fallopian tubes is that the thought is that most of the GYN, the ovarian cancers that occur in germline BRCA1 and BRCA2 carriers originate in the distal fallopian tubes. And obviously we can think if you just had to remove the fallopian tubes and you could leave the ovaries in place, you're not rendering these women menopausal at age 35 to 45, depending on where you're doing it. And obviously that would have significant health consequences for them. to say nothing of quality of life related issues to not being rendered prematurely menopausal. There are ongoing studies that are addressing it. I would urge you, if you're thinking about it, to recommend that your patient enroll in a study. That doesn't obviate the need for taking out the ovaries later, but the new NCCN guidelines place it more in a light that you can consider it and discuss it with your patients. And so I think that's helpful, but the way it's written is for patients who are not ready to have their ovaries out, because that's what we currently know is the best strategy in these patients. And then the risk-reducing hysterectomy we've already talked about in the prior, when we were discussing the prior slide. Just to also discuss things, we're going to talk much more about pancreatic screening in a later part of this talk, but I just want to remind you that the guidelines now say that for BRCA1 and BRCA2 carriers, you should be discussing pancreatic cancer screening if they also have a first degree or a second degree relative with pancreatic cancer on the same side of the family that the mutation is coming from. Okay? And then for males, we're recommending clinical breast exams starting at age 35 and self-breast exam teaching. And then we're considering mammography in germline carriers starting at age 50 and germline BRCA2 carriers. So let's go a little bit deeper into some of the new data on ovarian cancer screening. So you know that in the general population, it's not very useful, okay? The data in mutation carriers have also been that it's not particularly useful, but there are more recent studies that have come out that are a tweak on just doing CA125. So it's called this ROCA score, or the risk of ovarian cancer algorithm. It's a fancy black box thing out there. I mean, it's nothing fancier than doing the CA125 and looking at the slope of change of the serial CA125s. And that seems to be a more accurate way of looking at things than just using a cutoff of CA125 above 35 or whatever your institutional normal is for recommending further evaluation. And so this is a test that has been studied. There was a large prospective UK study that included thousands of women, over 4,000 women. It included 804 germline carriers. The question with this, right, is whenever you're doing a screening test, how many people have positives and what percent of those positives are true and how many people are you missing, okay? And so of those women, 3.1% were recommended to undergo surgery based on this screening. And about a third of them ended up having either ovarian cancer or fallopian tube cancer. If you looked at the stage of diagnosis, about 37% of them had stage 3B or 4, which is considered more advanced ovarian cancer. But if you looked at the women who were in that study in the post-screening time, the ovarian cancers that developed and were diagnosed, 95% of them had high stage. So it looks like there's a shift in stage. And then there was also a recently published real-world study from the UK, where again, about 2.5% of women were recommended surgery based on looking at this ROCA test. About a third of them were actually found to have ovarian cancer or fallopian tube cancer. And if you looked at the rate of higher stage disease, it was about 50%. So again, this concept that maybe we're shifting the stage. So I think for many of us who are seeing these women, if they're not ready to undergo either salpingectomy or risk-reducing salpingo-oophorectomy, we're doing CA125. It's a little hard to get ROCA testing outside of a study, although I'm sure it's available somehow. I haven't been able, I don't know if others know about how you can access this, but it seems like a more accurate way to evaluate this. I also just want to show you a recent publication. So if you have a PTEN mutation carrier, I'd have a look at this publication. This was by the group that is sort of the guru group on PTEN mutations. It's Dr. Eng's group. And what you can see is that there was a significantly elevated risk of both invasive and non-DCIS. There's an elevated risk for endometrial cancer, for thyroid cancer, for colon polyps, and colorectal cancer, and also for ovarian cancer. And for many of these cancers, they'd occurred at a younger age than you would typically see in the general population. So I think this is probably the study to look at if you're sitting across from a mutation carrier, PTEN carrier. The one thing that they made a comment about that's important is this was done through a collaboration with Myriad Genetics. Their standard panel that they do didn't actually have a lot of the thyroid cancer genes, and so patients might actually, with a strong family history of thyroid cancer, might have been tested through other means. So it's possible that this underestimates the risk for thyroid cancer for PTEN carriers. I now want to shift a little bit and talk about some of the other genes. And for those of you who've been doing this for a while, right, you got these like 30 gene, 80 gene panels, you got these genes, you had no idea what they were, and do they cause increased risk? I think these two studies are really, for me, the foundational studies now that really tell us what are the breast cancer susceptibility genes? What are the moderate penetrance genes that are associated? We know the high penetrance genes, right? There's BRCA1, BRCA2, PTEN, PALB2 I would put in there as well. You've got TP53, CDH1, and STK11, which is with Peutz-Jeghers. So you've got those genes that are the high penetrance genes. But what in that huge long list is actually a moderate penetrance gene? So these were two New England Journal of Medicine publications back to back, large international or US-based studies that included thousands and thousands of breast cancer patients that had unaffected controls that were looked at. And this was a large panel of genes that was looked at in both of them. And what I've highlighted for you here are the genes that are associated with an increased risk for breast cancer. Now, because many of the high penetrance genes, okay, are very uncommon, they didn't come out in this study, that doesn't mean that they aren't breast cancer genes. It's just they're so infrequent that it was hard to tease out in this study. But it did tease out for us what were the more moderate penetrance genes. So ATM, CHEK2 truncating mutations, those are the big ones and the most common ones that we actually see. But there's also BARD-D1, there's RAD51C and RAD51D, there's NF1, and MSH6 might be also a moderate penetrance gene. The important thing, and I think maybe this is already filtered in, but we were seeing lots of like NBN mutations. It is not associated with an increased risk for breast cancer. NBN, MUT-YH, and BRIP1 are not breast cancer-associated genes. And I found this publication really helpful for trying to sort out which patients, when these panels came out, what was actually associated with risk. This is from some of these publications looking at the actual risk for breast cancer, the lifetime risk from these two publications, so that you can see for ATM, there was about a 20 to 25% lifetime risk. I put up BRCA1 and BRCA2 here as well, just to show you the risks that we quote from the studies that were done in these high-risk populations that really were the individuals and families that populated the original studies that defined the risks, show slightly higher risks of breast cancer than are seen in these more population-based studies where it's closer to 50%, which still is a huge elevated risk, but it's a little lower than 80 or 85% than we typically quoted before. For CHEK2, there's about a 25% risk, and here in this one for PALB2, there was about a 32% risk. And similar findings also from the BCAC study. The ones above are from the carrier study, and BCAP is the one on the curve below. Now, when you're sitting across from a mutation carrier, right, you're trying to figure out what is her risk, because she's trying to make often very impactful decisions about risk-reducing surgeries. And I honestly don't think we have a good way to do this yet, but I am hopeful that we will have validation and ways to more individualize the risk for our patients so that we can make, recommendations that are based on what their risk is and how they view this and how this fits in with their life. So this was, again, a very nice publication that looked at incorporating the polygenic risk score and looking at how that impacted breast cancer risk in mutation carriers. So what I've shown you is the breast cancer risk by age 80 in those who didn't have any family history of breast cancer. They had a similar one for family history. And in green is the women who had the 10th percentile, so the lowest risk polygenic risk score. And in blue is the women who had the 90th percentile. So this interaction of a variety of lower penetrance genes, how that impacts the actual breast cancer risk for people who are found to carry a mutation. So for BRCA1 and BRCA2 carriers, the risk is still high, okay, period. But when you start to look at these more moderate penetrance genes, you can see how the polygenic risk score really influences things. So for ATM carriers, those with the lowest PRS score really had very low risks of breast cancer, not elevated over the general population, but the ones who had higher risk scores were much more at risk, and the same for PALB2 carriers. And this was just a depiction looking at, if you looked at the polygenic risk score, the percent of patients who slid below that 20% cut point that we use for MRI. And so for those without family history, just by example, about 47% or so of the ATM carriers who had no family history but had the lowest polygenic risk score actually fell below that 20% cutoff. So I think these will be useful things that we will be using to make determinations for what to do for our patients. I'm not going to walk you through this. This is my version of pulling out of the NCCN guidelines. The fact is, it's wrong now, probably, okay, because it changes all the time. What I would suggest you do is do what I do whenever I'm seeing a patient in clinic. I pull up the NCCN guidelines quickly to see if there's anything that's changed, unless I just put together a talk the day before, to really see what's out there. But I really think we need to be careful. I want to spend a few moments talking about contralateral breast cancer risk, because there, again, have been some interesting publications, and I really took the year in review seriously, okay? So I tried to look at what was new in what we're talking about. And so from the carrier study, this was a study that looked at the contralateral breast cancer risk, the cumulative risk, in mutation carriers based on their gene. And again, we know what's up there with BRCA1 and BRCA2, and I'm going to show you a bit more detail. For PALB2, there was also a marked increased risk for contralateral breast cancer. But for ATM and CHEK2 carriers, there was not a significant increased risk for contralateral breast cancer. And again, this is important for those of us who see breast cancer patients. Do these individuals need contralateral risk-reducing mastectomy at the time that they're diagnosed with their initial breast cancer? And if you looked at that, you can see what you're seeing in these populations is there isn't a huge increased risk for ATM or CHEK2 carriers at all, and that there is, though, an increased risk for PALB2 and BRCA1 and BRCA2. But what also has been found, and this is the case in many things in medicine, is things are nuanced, right? So the age of diagnosis of primary impacts the risk of contralateral breast cancer. So what I've showed you here is the risk if they're diagnosed when premenopausal versus postmenopausal. And I would just urge you to see that that's also true. This is looking at I think from this study, I think this is the 20-year risk that we're looking at here. And what you can see is the risk is significantly lower even for BRCA1 and BRCA2 carriers if they're diagnosed with their index cancer at age when they are postmenopausal as opposed to premenopausal. And then if we look at the impact of ER status, again, that's not surprising. Endocrine therapy reduces the risk of developing a new breast cancer in somebody who is taking it for therapeutic reasons. But the real thing that I want to show you this for is for the PALB2 carriers, the elevated risk of contralateral breast cancer seemed to be restricted to those who had hormone receptor negative disease as their primary. There's a new risk model that's out there that just you might be hearing about. I'm not going to go through this in great detail, but this is this model that is trying to incorporate some of the things that we've just talked about, younger age of diagnosis of first breast cancer, it looking at endocrine therapy use based on those data that I showed you for endocrine therapy. There's also some suggestion that if they have a first degree or second degree relative with a breast or ovarian cancer or where the mutation is located can impact things. And they have a nice little table that looks at various scenarios, and I just pulled one. So if you have a 55-year-old who at first diagnosis who has no family history and she has a germline mutation not in the 3' end and she's receiving endocrine therapy, her 10-year risk of contralateral breast cancer is very low. But in contradistinction, if they're lower, if it's at the bad part and they're not getting endocrine therapy, the risk is significantly higher. So the other thing that this was a San Antonio presentation. So we talk about, and I think we're all very comfortable, and it's our standard of care to talk to our mutation carriers with a breast cancer diagnosis at the time of their initial breast cancer diagnosis, should they have that risk-reducing mastectomy. I've given you some data about how you determine risk for that individual. So we know contralateral risk-reducing mastectomy significantly reduces the risk of developing a second breast cancer. But does it impact mortality? Okay. So this was a study, this was a huge international cohort study, 2,500, this was just germline BRCA1 with breast cancer, looked at the risk of contralateral breast cancer if they had breast-conserving therapy, unilateral mastectomy, or bilateral mastectomy. So obviously there was a huge reduction in risk of developing contralateral breast cancer if they had bilateral mastectomy. Interestingly, the mutation carriers who developed contralateral breast cancer, not so surprisingly, were twice as likely to die of breast cancer. But when they actually looked at the impact on mortality, there was no mortality impact if you compared bilateral mastectomy to breast-conserving therapy. Okay. For some reason, there was a difference in the women who underwent unilateral mastectomy. And again, these are registry studies, right? So these are looking back, and there might have been reasons why somebody chose to have a unilateral mastectomy that they could not control for. But there was no impact on mortality for having contralateral risk-reducing mastectomy in this study. So I think we need to continue to say that we don't have proof yet, but we do hope that there will be data on that. But right now, we do not have evidence that contralateral risk-reducing mastectomy reduces mortality in our mutation carriers. And this is in BRCA1, right? The ones who develop triple-negative breast cancer, were the ones that you're really worried that their chance of cure is impacted in a significant way. And then there was also some recent studies looking at gastric cancer risk in mutation carriers. So this is a large study that was just published in the New England Journal of Medicine. This is from a group from a biobank in Japan. I think everyone is aware that the risk of gastric cancer is much higher in Japan than it is in Western countries, so in South Asian and other Asian countries. So you're seeing here that a number of genes are associated with an increased risk of gastric cancer in this biobank study. What they found that was really interesting is H. pylori infection significantly impacted the risk of gastric cancer in these individuals. So it really suggests, if you can see this, you can see that in this curve, in the red, are the carriers who had H. pylori, and then you can see in the carriers in the two curves that are superimposed on each other, the carriers that were unaffected had a very, very low risk of developing gastric cancer. And what this suggests is maybe we should be screening for H. pylori in these individuals and individuals who carry mutations in these genes. The caveats, as I mentioned, is that this is a population study out of Japan, and that may not reflect what's going on in other countries, but it does raise interesting questions. The final screening area that I want to go to was pancreatic cancer screening. Again, there have been a number of publications recently from large studies that have looked at pancreatic cancer screening. One of the things that came out from this was this really nice table that outlined what the absolute risk was of pancreatic ductal adenocarcinoma based on these various genes. You've got the super high-risk genes like CDK N2A, but you're looking at BRCA1 and BRCA2 in this study again, has about a 2.5% risk by age 80 for this. So while the risk is elevated, it's very low. And so there was a couple of publications looking at pancreatic cancer screening. So this is looking at the CAPS, the Cancer Pancreas Screening Study 5, okay? It had about 1,500 patients in it. About half of them had pathogenic variants, so had mutations in the genes that we're thinking of, including BRCA1, BRCA2, ATM, PALB2, and Lynch syndrome, and they had to have at least one first-degree relative. What they found in this was that there was a downward shift in the stage of the pancreatic ductal adenocarcinomas that were diagnosed in the individuals who were having screening, and it also looked like their survival was better. But if you look in this huge study, right, there were 9 cases of pancreatic cancer that were diagnosed with screening, and screening is typically MRI, MRCP annually, or endoscopic ultrasound, and often those are alternated. So these were only detected in 0.6% of the individuals undergoing this screening. And there were also about another 0.5% or so who were found to have high-risk lesions where it was important for those to be detected. So again, this sense that maybe you're shifting the stage downward. And again, what you can see here is the individuals who participated in this, they seem to have a much lower risk of developing or being diagnosed with higher stage or metastatic pancreatic cancer. And the non-screened, about 85% of them had pancreatic ductal adenocarcinoma. So I'm running out of time. I'm just going to go to the final slide here about who to test, okay? And I just want to show you the very latest guidelines from ASCO and the Society of Surgical Oncology. And I just want to make a point of this. The guidelines have changed. There are data behind it, and if you can see my slides after, you'll see the data that really led to this. But the recommendation now is that for our breast cancer patients, all newly diagnosed breast cancer patients under the age of 65 or 65 or under should be offered genetic testing. Okay, that allows you to miss very few BRCA1 and 2 mutations and very few other high penetrance or more moderate penetrance genes. And then if they have other risk factors or other things where there's universal recommendations, triple negative, male breast cancer, if somebody has Ashkenazi Jewish ancestry, all of those things, then you would do it across the board. And obviously if you're making any determination for use of PARP inhibitors. But I just want to make sure that you know these data because that changes things. And you also know these data because many of us are following tons and tons of breast cancer patients. Look back and figure out how old they were when they were diagnosed. If they meet the criteria today, we should be sending them for genetic testing. So I'd really like to thank you for your attention. I photoshopped this, and a number of years ago, I got permission. I paid some amount of money, but this says I'd have been here sooner if it hadn't been for early detection. And I think that's what genetic testing is these days. So thank you very much.
Hello? Yes, okay, great. As you can tell, that was a great year in review, and I feel like those are some tangible take-home